Okay, so we are going to roll right into our mass characterization PowerPoint. This is taking what we just learned in our initial PowerPoint a step further. So we're no longer talking just kind of about characteristics in general. We're talking about what happens when we find something that doesn't belong when we're scanning. So we kind of referenced how we categorize and characterize different organs while we're scanning, what some of those organs should look like in terms of abnormal versus normal. But this is going to be while we're scanning something and we happen to see something that we know does not belong. How do we characterize that in order to categorize that finding? So just some terms we have to talk about really quickly before we get into specifics. Mass, lesion, nodule, these are all terms that we give to something that we see while we're scanning that we don't really know what it is yet, or we're not 100% sure until we get a biopsy or we get a tissue sample. There are certain terms that are a little bit more specific, but these three terms are typically kind of used interchangeably with each other. We don't really say that a mass versus a lesion or versus a nodule is more likely to be benign or malignant than another. It's kind of just the general term that we give to something that we see depending on where it is or depending on the patient's medical history. So when we say the word mass, that's kind of the most general term that we can give something that doesn't belong. So we're scanning an organ, we see something in that organ, and we are just going to term that a mass. Now, a lesion is going to typically be in response to some sort of disease or trauma within an organ. So this is going to be more organ specific. Maybe they have a known liver disease going on and we see a lesion forming in response to that in the liver itself. A nodule is going to be when we have swelling or aggravation of cells within the body. This does not need to be in an organ or a particular organ system. We can kind of see nodules everywhere. So again, depending on where we happen to find this finding, we would term that a nodule. So again, very similar to each other. They do have their slight differences. So depending on where we're looking, depending on where we see something, we may use a lesion versus a nodule. So why do we have to categorize and characterize specific masses? What is our purpose? Why can't we just show the picture to the radiologist and say, you figure it out? Well, there's so many unknowns in terms of pathology and in terms of diagnosis from imaging that we want to be as precise as we possibly can. So there's a certain criteria that we have to abide by in order to help the radiologist give a precise diagnosis to that patient's physician. That diagnosis is really going to help determine the course of treatment or the plan of action for that patient. So we need to make sure that we are as precise as possible. So here we have two images, and if we're looking at the anechoic regions in both of these pictures, probably thinking, well, they're both kind of oval in shape and they're both anechoic, meaning that they're both black, and they both kind of look like they're in the liver from the previous liver pictures that we've seen, right? So if I outline these areas that I'm talking about, you'll learn that this top one is a mass and this bottom one is a normal gallbladder. So although these two structures have very similar characteristics to each other, we have to know what is considered normal versus abnormal. And we'll learn about that as we go and we learn about these organs and the systems. So when we find a mass, when we find something that we know does not belong, again, we're not going to know what doesn't belong for a little bit of time here. We have to kind of figure out what is normal, but before we can figure out what is normal, we have to learn these terms and we have to be comfortable with these terms to help us build that basic knowledge of this organ looks normal, this finding looks normal, or it looks abnormal, so on and so forth. So when we're categorizing and characterizing these findings, we have to make sure that we are aware of their border and shape. Border and shape of masses typically go hand in hand with each other, and those will be the first things that we talk about. So when we're talking about the borders, we're kind of looking at the outside structure of that finding. Is it smooth? Is it kind of lobulated, which we'll talk about in a minute? Does it have an irregular border in terms of the shape? Is it round? Is it square? Is it irregular? Is it spiculated? We'll talk about what that means as well. In terms of echogenicity, does it have any internal echoes within that structure or that finding? If it does, it's going to be echogenic, and therefore is it hyperechoic or hypoechoic? Is it anechoic, meaning that there are no internal echoes? Is it similar in echogenicity to a surrounding structure, meaning it's isoechoic? The texture and the internal architecture are going to go kind of along with that echogenicity. So the texture, are those echoes nice and uniform and aligned? It's smooth, or are they a little bit chaotic and they're kind of occurring at random parts, meaning it's rough and coarse, kind of having a cobblestone-like appearance? In terms of that echogenicity as well, is it nice and uniform in its echogenicity, so it has the same shade of gray throughout, homogeneous? Or are we seeing mixed levels of echogenicity? We're seeing some areas that are hyperechoic and hypoechoic. That's going to lead us to believe it's more heterogeneous. Does it have any sort of posterior behavior, meaning through transmission? Are we seeing enhancement from a low attenuation structure, or are we seeing shadowing from a really high attenuation structure? And then the size of these findings is really, really important. So the way that we measure mass or finding is critical. A lot of patients will come back for follow-up exams or scans, and we have to make sure that we are measuring these areas precisely, because even the slightest change in size can indicate some sort of abnormal growth. So we'll talk about how we measure as we go through this PowerPoint. So like we said, oh, sorry, I got one slide ahead here. So documentation, we want to make sure that when we find something that doesn't belong, we are documenting it in multiple images. We don't just take one picture and call it a day and give it to the radiologist and say, hey, I found this thing, here's one picture. We don't need 100 pictures of a mass, but we need a couple. So we have to show in multiple pictures. We have to show what that finding looks like in grayscale, meaning just our black and white photos. We need to make sure we're measuring that in multiple photos. We need to make sure that we're putting color evaluation on that to pick up any sort of blood flow. Does it have small, very sensitive, slow flow vessels? If it does, we have to put color powered Doppler on that. That's all going to accumulate in terms of multiple images. We also make sure that we have to, in those multiple images, are looking at that finding in multiple planes. So we're documenting that mass in sagittal and transverse and coronal if it's appropriate. We're documenting throughout those pictures the borders and the shape of it as well. So we're looking to see, does it have smooth borders, nice and obvious borders, or is it a little bit more discreet where we can't really pick out the border? It's a little bit harder to tell the shape of it. Is it oval versus irregular? So we're making sure that we are obtaining as much pertinent clinical information about those findings as possible so that we can relay that to the radiologist. So we said first, we are going to be talking about our borders and our shapes, and just like the previous PowerPoint, I've had to record this one a few times already. My husband tried to FaceTime me with the baby, so I got a little distracted the first time around. So we have some drawings right here on the slide, but we will get to that in a second. So borders and shapes, like we said, they typically go hand in hand. Border is kind of talking about the outside appearance of a finding, whereas the shape is kind of talking about that actual shape of the finding overall. So when we have something that's well defined, that border is going to be nice and smooth. It's going to pop out, it's going to be obvious. We're going to see a nice delineation between the mass and the surrounding tissue. Typically, when we have something that is round or oval in shape, it's going to have a nice, well-defined, smooth border. Those are typically going to be benign findings. It means, hey, whatever's going on in this little area, whatever mass this is, at least it's contained. It's trying to stay well behaved. It's minding its business. It's not trying to spread into nearby tissues. Now, when we have some more malignant variations of border and shape, that's when we get into some irregular or spiculated borders and shapes. When we have irregular borders, we see this little star-like appearance here. I'm going to change my color just because I did blue the first time. Here are my irregular extensions. These are areas typically of a malignant mass that are trying to spread into nearby tissues. So these are little pathways that the mass is trying to take outward into the neighboring tissue to affect it negatively and to spread that malignancy easier. Now, when we have something that is neither round or irregular, it's typically going to fall into the category of lobulated. So it's usually not going to be perfectly round, but the edges of it aren't super sharp. We don't see those little finger-like projections or extensions like we do with an irregular or a spiculated mass. So we kind of see these little bumps in the road. So here we have a lobulated mass. these are going to be findings that kind of have a cloud-like appearance or shape to them. Now, lobulated masses typically fall right in the middle. It can either be benign or it can be malignant, depending on the size and the number of lobulations that it has. So if the border of a mass has more than 3 small lobulations, that's going to mean that it's most likely going to be malignant. So the more lobulations you have and the smaller they are, the worse it is in terms of prognosis or in terms of diagnosis. Now, when you have really big, chunky lobulations and you don't really have that many of them, you typically have less than 3, those are going to be considered macrolobulations, and those are going to be a little bit more benign looking. So this little diagram here, this one that I highlighted in red, those are going to be macrolobulations. They're big, they're chunky, they're bulky. If you look directly underneath it, we can see those microlobulations, and it looks a little bit smaller. They're a little bit more in occurrence. That's typically going to be more of a malignant lobulated finding. Now we mentioned spiculated as well. This is where we have that irregular border, but those extensions are really drastic. So we have these little branches that are coming off of the root of that mass, and they're really trying to get into nearby tissues. Here we have obscured, meaning that this border is a little bit harder for us to see. So maybe this border is nice and round and smooth. When we're looking at that anterior border, we can't really figure out what's going on. Maybe it's really blurry or really fuzzy. That doesn't mean that it's most likely round and smooth, but we just happen to not really see the other edge of it. That means that it's an obscured border and that it's probably not round and smooth, that it probably has an area to it that is trying to spread out into nearby tissues. So we can't just assume that something is going to be round or oval just based off of one border of it. We want to make sure that if it's round or oval and we're going to most likely call it benign, that we see that picture with 100% certainty. We see that finding with 100% certainty, and we're not missing any of the borders to it. So here we have some great examples. This picture right here on the left-hand side showing nice round, smooth, well-defined mass. You can see the clear border going right around it. There and kind of went over there, and we have some nice increase through transmission, so we have some enhancement coming down posteriorly through the picture. That's going to tell us that this anechoic structure is nice and low attenuating, so everything is behaving nicely, and there's not really anything of concern with this picture. Now the picture's on the right hand side. We're starting to move away from that nice round, perfectly oval shape. Picture on the top, you're probably thinking, well, it looks pretty oval to me, but there's a little lobulation here or macrolobulation there. And then we also kind of see this area that's a little bit strange. So I can't really tell what's going on in that area. Is it angular, meaning it's a little bit box-like in its shape? Does it have a jagged extension that's trying to come out from it? I don't really know, so I can't call that perfectly oval. This bottom picture here, I see all of the borders pretty well, and I can't call this oval, but I can certainly call this lobulated because I have one lobulation here, and then I have some other lobulations here. So would I call that macrolobulated or microlobulated? Probably call that microlobulated, and I would want to question that further. Here we have some more pretty obvious findings here. These are going to most certainly lead our eye to believe that they are going to be malignant. They have very obvious lobulations and spiculations. So they're very pointy, especially this little guy right here. There's an extension right there. And then look at all of this crazy shadowing underneath it. This is saying that this finding is very, very dense, and it is attenuating a lot of the sound beam, so it's going to produce that shadowing. Malignancies, cancers, they're very, very dense. Cancer cells are heavy, they're hefty. They are like heavy-duty cells, so they are going to be very, very dense, and they are going to absorb a lot of that sound wave, and that's why we get a lot of that shadowing posterior to them. This picture in the middle, the borders are a little less obvious than that first one on the left-hand side, and that's what makes finding malignancy so hard. Sometimes when we're scanning through certain tissues, we can get this natural shadowing that occurs from either ligaments or tendons in the body, and it can be very easy for us to sweep right by something that's giving us shadowing if it doesn't have very obvious borders. So the borders of this mass are very, very discreet, and this is actually the entire shape of the mass. So not as clear cut as that picture on the left-hand side, still producing a lot of shadowing, still has these extensions that are kind of branching out from the root of it, showing those spiculations. And then this picture on the right-hand side, again, borders are not super clear cut. Typically things that are benign are gonna make themselves well known. They're gonna pop up and they're gonna say, hey, how you doing? Whereas malignancies, they're gonna try to hide. They don't wanna be found out. They don't wanna know. They don't want us to know that they're there because they're trying to destroy the patient. So these are gonna be a little bit harder for us to see. And this may catch your eye, but you may be wondering what the border is, and it's this whole area. So again, very irregular in shape and how they're behaving, very hard for us to pick out right when we're first starting to scan. Here we have some more. This 1D, pretty obvious, right? It's kind of round in its shape, but it has a microlobulation. It also has some calcifications in it, these little micro calcifications, and it is shadowing. It is very dense. It's giving us decreased retransmission, giving us lots of shadowing. Now the rest of them, you're probably thinking, oh my gosh, I don't even really know where the border is. See right here, these are all malignancies here. So here's that border. We also have microcalcifications. We have heterogeneity here, so we're seeing different shades of gray. Same thing with A and B, different shades of gray. Here's A. We're kind of cutting it off a little bit in our field of view. And then B is actually this whole area, and it's not just the sky right here. So really, finding these borders is very important. If you were to measure, say B for instance, if you were to measure that and you said that here is your length, and here is your height, and say it measured, I don't know, 2 centimeters by 1 centimeter, when in reality it was that whole area that you didn't measure here to here, and it was 10 centimeters by 12 centimeters. And we really kind of just changed the trajectory of that patient's healthcare journey with this diagnosis. So you really have to make sure that you know what you're looking at, you know how to find these areas, and you know how to document them. Here we have some more examples. So here on the left-hand side, we're showing a hyperechoic mass in the liver. This is showing a nice, not nice, but pretty irregular shape in and of itself. Very pointy, so that's going to lead us to believe that it is going to be a malignant finding. And then here's another picture of a liver where we find these hypoechoic little lesions everywhere, and we're not going to necessarily treat each of these lesions as their own mass. This is an overall disease that is occurring within the liver, and that's why we're calling them lesions. This is a liver disease, and this is metastatic cancer to the liver. So we're not going to necessarily go in, oops, I overmeasured that one there. We're not going to go in and measure each little individual hypoechoic mass that we find, because we would be there for days. When we see something like this, we're going to measure the 3 largest, and we're going to evaluate the 3 largest or the 3 most malignant appearing areas within that organ. Okay, so when we term something as cystic, that is going to be, it has to represent a completely anechoic echogenicity, or rather just non-echogenicity, no internal echoes. We want to see that it has enhancement, it's homogeneous, well-defined, smooth borders. So here we have a picture of a liver cyst. We can get cysts, let me backpedal here for a second. We can get cysts that occur anywhere in the body. A cyst is going to be an accumulation typically of serous fluid, and all of our organs produce their own type of serous fluid. So we can get a cyst that occurs anywhere in the body. We can get cysts in our skin. We can get cysts in our liver, in our kidneys, in our ovaries, in the scrotum. We can get them literally anywhere. So when we give something the term cystic, we're saying, hey, this isn't most likely a benign cyst if it meets all of these characteristics. It's perfectly anechoic, it has enhancement, homogeneous, well-defined with smooth borders, and it's oval in shape. So that is something that we term cystic for a cyst. Next we have solid. Like we said, anything that's going to produce echoes or have internal echoes is going to be made up of solid tissue. So now we're talking about anything other than a fluid. These are usually going to be, depending on if they're benign or malignant, either hypoechoic or hyperechoic. So if it is a solid appearing tumor, meaning it has some sort of echogenicity to it, but it's well defined and smooth with smooth borders, most likely going to be benign. But if it is irregular, has rough borders, it's most likely going to be malignant. Regardless of benign or malignant, it can be hypoechoic, it can be hyperechoic. It could have unchanged through transmission, meaning nothing happens posterior to it, or it could have shadowing, or it could have enhancement. It can have any of them. It could be homogeneous or heterogeneous. So just because something is solid does not mean that we can kind of lean one way or another. We go mainly off of the borders to help us to determine that, and more so in the malignant sense. So anytime we see a sharp border or an irregular border or a spiculation, that is usually always going to be malignant. We don't see sharp borders with something that's benign. So top picture here, we're talking about this hyperechoic round mass right here. It doesn't have any change through transmission, so it's not producing any enhancement or shadowing posterior to it, but it's nice and round, it's homogeneous, it's hyperechoic, and because it's round, we could say most likely going to be benign. Now this picture here on the bottom, it's hypoechoic, so it's the opposite of that first one, but it's still round, it has enhancement, and it is nice smooth borders, so that is also most likely going to be benign. Next we have complex. Now in our last PowerPoint we talked about how this is something that we typically don't want to see. We don't want to see something, we don't want to find a mass that is complex, because that means it is an intended fluid-filled structure that has a solid component. So it's the solid component of a complex finding that we worry about. We shouldn't see a solid component to a cyst, because then it's no longer just a cyst. A cyst, we know, is going to be benign. If we see a solid component to the cyst, it's no longer going to be benign. It's no longer just a cyst. Now it's a complex finding. So this is automatically going to make it heterogeneous because it has both cystic and solid components. And so we give it that term complex because we're not sure. We don't know what to do with it. Now, something that kind of throws our mind for a loop a little bit when we're learning about normal anatomy, so now we're not talking about just mass, we're talking about normal anatomy, both ovaries and kidneys can technically be considered complex because they have internal structures that are fluid-filled cystic regions. In our kidneys, we have our pyramids. The pyramids in our kidneys are fluid-filled cystic structures. But then the cortex of our kidneys is solid tissue. So both solid and cystic component in the same structure. Same thing with our ovaries. We have normal cortex in our ovaries, normal ovarian tissue, but then we have follicles in that ovary as well. Those follicles function as normal cystic areas. So a little kind of a brain tease there is that you have organs that can or should be benignly complex because of how they're composed, but when we're talking about a mass or we're talking about a finding, we don't want to see complex because that solid component is what we're concerned about. That solid congregation of tissue and cells is going to lead us to believe that there's something more serious going on. And here on the right-hand side, this is our picture of an ovary. So this is our ovary. Here's our ovarian border. Oops. And then there are our multiple cystic follicles inside that ovary. Both of these two images here are complex mass findings. So both of these are worrisome. And this terminology, that should not say cyst, because like we said, anything complex is no longer just a cyst. Okay, calcifications, we talked about these a tiny bit so far. These can occur for a variety of reasons. So whether it be a benign or a malignant process, we can see calcifications, and how they present themselves really matters in terms of helping to determine and categorize that finding if it is benign or malignant. They're typically going to cause shadowing and decrease through transmission. So we see any sort of calcification in the body means it's going to be a little area of a high density. So when you have calcifications in the body, they're very firm, they're very hard, they're very dense. So as a sound beam hits that calcification, we're going to see shadowing posterior to it. Now we say typically because that's usually going to occur for larger calcifications. Smaller calcifications, microcalcifications, are usually going to produce what we call a comet tail. Now if we look at our pictures here, picture on the bottom, this is a gallstone, so this is going to be a big calcification, very hyperechoic, very dense. We know it's going to produce shadowing, decrease through transmission. Picture on the top here, these are microcalcifications within a mass. So these are very, very, very small, and they kind of give like a starry appearance to them. These produce a comet tail appearance. So when you're looking at the sky at night and you see a comet or a shooting star go by, it kind of has that little tail or that ring that follows it, and that's exactly what these are. So this is the microcalcification, but this is the comet tail artifact that follows posterior to it. So again, bigger calcification is going to produce shadowing, smaller microcalcifications are going to produce a comet tail. When we put color on these findings that have calcifications, we're usually going to see what we call a ring down artifact, or sometimes people still call it the comet tail artifact with color on it. We'll see it kind of produce this color artifact that goes posterior to it. I'll see if I can post a picture of it in your module just to make sure you have a good understanding, because I don't have a picture of it in this PowerPoint. Let me just write myself a quick little note. But it makes this really pretty appearance when we put color on it, and it helps us to confirm that it is in fact calcification. Okay, so now if we happen to see calcifications, a benign calcification is usually going to be something that is a really old mass. It's been there forever, and now that mass is starting to die. Usually people leave benign masses alone. So say we find something in the body, we take a biopsy of it, we find out it's benign, it's not going to kill you, it's not cancer. People usually leave them. When people leave them, they have them for pretty much their entire lives. Those masses get to a certain age and they say, okay, I'm done. I don't feel like being a mass anymore. So they start to die off, and that dying process of a mass is called the degenerative response, or degeneration. That response is when the mass says, okay, I don't need any more blood flow. I don't need any more supply keeping me alive. I'm just going to slowly kind of go to sleep. I'm going to go dormant. The masses start to shrivel up, they start to become heterogeneous if they weren't already, and they start to get calcification replacement in response of those benign tissues in that mass. So we typically see calcifications forming in old masses that are starting to die off. We also see benign calcifications in diseases that produce high levels of calcium. So when we have a parathyroid imbalance, we get high levels of calcium in our body. That calcium has to kind of settle somewhere. So it kind of settles in our kidneys, it settles in our thyroid, it can settle in nodules in the body. When we have malignant calcifications, this is when we have cancer cells that are producing calcium. So it's kind of hard to tell, is this calcium producing disease a normal disease, or is it a response to cancer cells producing that high level of calcium? So it really is important for us to get a very clear patient history and make sure that we have really accurate blood work on the patients as well. Microcalcifications are going to be when we see these calcifications and they're really, really small, less than 1 millimeter in size, and anything greater than 1 millimeter is going to be considered a macrocalcification. And again, whether it be microcalcs or macrocalcs, it doesn't really mean malignant or benign one way or another. Where we can determine if it's malignant or benign is with that patient history. So have they had this benign mass for 20 years and now all of a sudden we see calcifications in it? Yep, most likely still going to be benign. Do they have blood work proving that they have a parathyroid disease that produces high levels of calcium? Yep, okay, great, most likely going to be benign. So those are really important questions to keep in the back of your mind. Now, we do have some imaging principles that we have to be aware of when we do find masses, and we have to document them. And that acronym is going to be SALT, and this stands for size, shape, acoustic characteristics, location, and transmission. Those are all of the non-vascular criteria that we need to obtain when we are taking our pictures. So yes, we're taking pictures in multiple images, we're taking pictures in multiple planes, we're documenting the border, the shape, all of those things, but we also need to make sure that we are documenting where that mass is and the through transmission and the other acoustic characteristics as well. So it's kind of combining all those categories that we talked about in those first few slides of this PowerPoint into this acronym to help you remember. So size, like we said, very, very, very important for us to be able to know how to measure something precisely. We want to make sure that we are documenting size in sagittal and transverse. Typically, we're not going to be using the standard sagittal transducer position and transverse position of the transducer to obtain sagittal and transverse mass measurements. And you're probably thinking, what the heck is she talking about? When we are doing sagittal and transverse mass measurements, it needs to be sagittal and transverse to the mass. And that means that the mass doesn't have to lie perfectly in correspondence with the true sag and true transverse of the patient's anatomy. So say you have patients, let's just do the patient's belly right here. So that's their belly button right here. Here's their xiphoid process up here. There are their arms, just for a little reference. So say we are looking at the patient's, let's do their right kidney. Let me change my color here. Patient's right kidney is going to sit like that. But say we find a mass in that kidney that the longest part of it goes like this, right? So say there's a mass like that right at the end, right at the inferior border of that kidney that kind of sits elongated like that. Now, for us, for our transducer, we would typically measure that as a transverse measurement. But because that mass sits the longest in that perpendicular plane, we need to measure that as a sag measurement. So meaning we're getting a length and a height in that view, and then if we were to turn our transducer sagittally, that's how we would get our transverse view. So when we're talking about masses, we need to be aware of what the longest measurement is for that mass. The longest measurement of the mass is always going to be how we take that picture, how we take that measurement. And then we're always giving a perpendicular to that longest measurement for our height. So let's look at our diagram here. So we have our elongated mass, we have our red measurement, that's going to be our length, that's going to be our longest measurement. Our blue measurement directly perpendicular to that length, that's going to be our height. Now we change our orientation to that mass to get a cross-section view of it, and that's where we get our width. Okay, so our transverse view. We want to make sure that we're not being so stuck on what our transducer is doing and what the patient's body is positioned like in reference to that transducer. When we're documenting a mass, it always has to be the longest possible plane for that mass will always be our length. And then from there, we measure perpendicular for a height, and then we turn completely on a cross axis to get a width. Be a little bit confusing at first. Okay, so kind of just piecing that all together, some of the things that we've already spoken about, benign versus malignant. Typically, benign findings will be cystic. They may have macrolobulations, they're usually going to be round or oval, well circumscribed, so meaning those borders are well defined. Homogeneous, typically. Hyperechoic, typically. Want to kind of put a little asterisk next to homogeneous and hyperechoic because those are interchangeable with malignant findings. Usually they're going to be wider than they are tall with their measurements. They're usually going to exhibit enhancement because it's going to say, hey, this finding is not super dense, right? Cancer cells are very dense. And they're usually going to have macrocalcifications unless otherwise indicated by a benign calcification or calcium disease. So put a little asterisk next to homogeneous, hyperechoic, and macrocalcifications. Now, malignant findings typically going to have microlobulations, spiculations. They could be angular in shape. Those are going to be clear-cut malignant findings. Hypoechoic, again, sometimes we have malignancies that can kind of throw us for loops that all of a sudden, we're used to seeing hypoechoic malignancy, hypoechoic malignancy, hypoechoic malignancy. All of a sudden we get a hyperechoic malignancy, and it really throws us for a loop. So again, put a little asterisk next to that. Typically, they're going to be taller and wide because they're trying to invade nearby tissues. They don't care what's going on around them. They can just invade anywhere. Whereas benign findings, if they happen to grow, they kind of just spread upward. They kind of just move everything wider. Malignancies, they'll just go right through the different layers of tissue. They usually will produce shadowing, but again, be aware, is that shadowing coming from, a benign macrocalcification? If it is, it doesn't mean that it's malignant. And then microcalcifications as well. So again, put a little asterisk next to hypoechoic with our shadowing and microcalcifications. We want to make sure that you know which scenarios would produce malignant findings of those categories versus benign findings of those categories. And then again, indeterminate, like we said, just because something is solid does not mean that it falls into one category or another. Complex, again, is it an organ, right? Because if you're looking at the ovary and you call it a complex mass, well, you're going to be having a conversation with the radiologist. And heterogeneous. So in addition to different levels of echogenicity and causes of calcifications, we do have some indeterminate findings as well. So please make sure you guys reach out to me if you do have any questions about both of these PowerPoints. Hopefully they kind of piece together well with each other. This will make more sense when we start scanning in lab and we start learning what is normal versus not for certain organs and certain findings. I'm sure some of you guys will have some benign pathology going on that we can take a look at. That's always fun and interesting. So please make sure you have a good understanding of this. If you have certain questions about specifics or maybe some broader topics, please don't hesitate to reach out. Sometimes I can explain things in a different way or give you a different example with some additional pictures. So please reach out.